Hello guys, today we start talking about the disease of the fingers and hand. First of all, I want to give you general information about the Panorytium. We will talk about this one. In Russia we call it Panorytium. In English literature it is the Felon. Specificity are classic Panorytia of the volar side. The most common errors in therapy: postponement of surgery, incorrect localization of incision, imperfect immobilization, inappropriate antibiotic therapy, failure to perform X-ray. Panorytium is a purulent affection of the fingers, mainly staphylococci, less streptococci, fungi, erythropelotrix. It is the etiology of Panorytium. Cause: minor injuries improperly treated. The back of the hand, except the nails, has an infection like elsewhere on the skin. Classification: we have few types of the Panorytium: subunguale, cutaneum, subcutaneum, button-like, tendinum, tendovaginosum, V. phlegmona, Panorytium osseum, and Panorytium articulare. Panorytium subunguale. It is often caused by a foreign body, chip. There is a purulent deposit under the nail, swollen parenchymal tissue, pain on pressure. Treatment: fenestration of the nail above the bearing in larger ones, partial or total nail removal under seductive anesthesia, removal of necrosis, antiseptics, dressings, immobilization, finger baths. Panorytium cutaneum, subcutaneum, button-like. They affect the volar part of the finger, most often the distal joint. Epidermoid cutaneum, purulent blister, pulpous subcutaneum in the belly of the finger. Button-shaped form combines the two previous forms in the shape of a cufflink. Significant throbbing pain, temperature, limited mobility of the finger, edema on the dorsum. Therapy: incision from both sides. Panorytium tendinum, caused by progression of subcutaneous panorytium or direct tendon injury, swelling of fingers with relief grip, pain when moving. Due to the anatomical arrangement of the tendon sheaths, phlegmon can spread from the side of the little finger to the thumb, leaving out the middle space, so-called V. phlegmon. Sheaths of tendon 2 for the fingers and more distally. Treatment: during hospitalization in CA or LA, axillary block. Opening of the tendon sheath, repeated irrigations with a tube for several days. Immobilization with a plaster bandage. Treatment of native Panorytium: V. phlegmon, opening both spaces, cutting the retinaculum of the carpal tunnel to release the median. Panorytium osseum: it is usually a complication of poorly treated soft tissue panorisis. In 2-3 weeks for X-ray, periostal apposition, superostal abscess, fusion of phalanx, sequestrations, the fingers is swollen, painful. Therapy: incision dorsally, evacuation of pus, removal of sequestration, irrigation and application of ATB ointment. Cast ATB several weeks. The regeneration capacity of the periosteum is considerable. There is no point in rushing with amputation. Panorytium articulare restricts joint function, source most often from the surroundings, less often in case of injury. A few words about phlegmon of the palm and phlegmon of parent space. Panorytium in the middle space between the osteofascial space of the tenor and hypotenor. Space is divided into ulnar, third and fourth MTC, and radial, second MTC space. Both spaces connect at the carpal tunnel and at the same time communicate with the forearm through the same channel with parent space. Source follows on from an external injury. The gate of infection can be seen on the hand: redness, edema of the dorsum, pain on apposition of the thumb. Treatment: excision of a wound or bearing, wide opening of the space while respecting the lightness in the palm, long-term mobilization with the splint in a functional position. The splint goes up to the forearm, fingers in semiflexion, slight dorsiflexion in the wrist. Deep phlegmon of the forearm. Yes, this is the V. this is the V, and this is a Purulent space. Yeah, you see that we have a space with second, third, fourth finger, yeah, and the first and fifth finger have the lone space. What will connect there? Purulent space. It can proceed as a life-threatening infection with manifestation of sepsis. Anatomy of the space: it is an imaginary space ventrally on the forearm in the front group of muscles. It is the space between the third and fourth layer of the front group of muscles on the forearm, below all the flexors of the fingers and above the pronator quadratus and flexor digitorum profundus. Yes, it was the general information, and now I want to tell you more about the Felon and about the Paronychia. What I want to tell you, the first pictures about the Panorhythium, about the Felon, there was mistakes. Why? I will tell you in the next slide. Felon is an infection that occurs within the closed space compartments of the fingertip pulp. The swelling leads to intense throbbing pain. The surrounding tissues are at risk for ischemia if the blood flow is compromised by compression from edema and pus formation. Yes, there you see how the finger looks like, and I please you remembering that just a fat pad can, just the fat can be in the purulent situation, and you see where we have the fat, yeah, and where we can have the Panorhythium. Etiology: any injury to the fingertip may predispose to a Felon, including minor cuts, foreign body penetration, splinters, and paronychias. Staphylococcus aureus is the most common bacteria associated with Felons, and always gram-negative organisms can be found in immunosuppressed individuals. Epidemiology: Felons along with Paronychias account for almost one-third of hand infections. Felons most commonly occur in the first and second digits of the hand, first and second. They are most commonly caused by penetrating trauma. However, anything that introduces bacteria into the digital pulp can lead to Felon formation. Splinters, picture, wounds, beads or glass, abrasions or beads can all be inciting factors. Paronychias are another common cause, and about Paronychias we will talk in a few slides away. A Felon is an infection that occurs within the closed space compartments of the fingertip pulp. The infection may initially start as cellulitis, which can progress to abscess formation if not treated early. The compartments of the fingertip are divided by vertical fascial strands known as septa, which run from the periosteum of the distal phalanx to the skin. This fibrous septa provides structural support of the pulp and form small compartments. Blood flow may be compromised when edema and infection form in these non-compliant compartments, which in turn can lead to skin and pulp necrosis. The swelling in these small compartments causes the severe pain associated with Felons. Septa may also impede complete drainage after an incision and drainage procedure if they are not properly separated. If not properly treated, Felons can progress to osteomyelitis, tenosynovitis, and septic arthritis. Yes, there in the picture you see the Paronychia, yeah, near the nail it is the Paronychia, and there you see the Panorhythium or Felon. The patient may recall trauma of the finger, but often no inciting source is identified. The patient may describe that they first noticed erythema of the fingertip, which later became edematous and painful. The pain may be mild at first but rapidly progress to severe and throbbing. The presenting symptoms include tissue tensions, throbbing pain, edema, and erythema of the fingertip, pulp at the distal phalanx. Typically, the edema will not extend proximally to the distal phalanx due to compartments defined by the septa. The pain is often severe and worse in the dependent position. Spontaneous drainage may occur due to the pressure in the fingertip, which may result in temporary relief. However, if not properly incised and drained, the abscess will reform. Evaluations. The diagnosis can often be made based on clinical exam. The distal phalanx may be erythematous and edematous with tense tissues and fluctuance. The fingertip may be extremely tender to the touch. It is important to note any bony abnormalities and assess for signs of ischemia. Imaging should be performed if there is a history of a foreign body penetration. Imaging can also identify fractures, osteomyelitis, and gas formation in the tissues, which may lead to an alternative diagnosis. A gram stain and culture of any discharge or drainage should be obtained to help guide antibiotic therapy. Yeah, there in X-ray you see that something wrong with the bone of the third finger. And this is a osteomyelitis. We see the osteomylation of the bone. Please remember that the most important in this case is the X-ray. If abscess formation has not yet occurred and the felon is in the cellulitis stage, it can be treated with antistaphylococcal and antistreptococcal antibiotics. Warm water or saline salts and elevation of the fingertip will also aid in recovery. If abscess formation has occurred or if tension or fluctuance are present, incision and drainage must be performed to drain infected material and maintain venous blood flow to the finger. Due to the fibrous septal forming multiple compartments, it may be difficult to fully drain a felon, and debridement in an operation room by necessary. There you see the artery and the nerve, and where we need to do the cutting. Yeah, and in this region, 3-5 mm from the distal interphalangeal joint, yeah, and we do the incision. It is important to remember and where we need to do the incision. A digital block should be performed prior to incision and drainage. Bupivacaine has the advantage of a longer lasting anesthetic effect than lidocaine. A finger tourniquet can be used to decrease bleeding and aid in visualization of structures. The area of maximal swelling and tenderness should be located for optimal drainage. For deep phalanx, a single lateral incision should be made. Look, there you see the nerves, what we have in the finger. And there you see the incision, what you need to do the block of the digit. Treatment management. The incision should be made at least 0.5 cm distal to the deep in order to avoid injury to the flexor tendon sheath, digital neurovascular structures, nail matrix, and to avoid contracture. The incision should extend parallel to the nail plate. It is important to maintain a distance of 0.5 cm from the nail plate. They avoid injury unless there is an obviously paronychia, which should also be drained. For complete drainage, it is often necessary to use blunt dissection to separate the finger septa with a small blunt hemostat. If there is necrotic tissue present, it should be excised and the abscess should then be decompressed and irrigated. The wound should be packed and the finger should be splinted. Yeah, you see, we do the cut. We, with the clamp, do the blunt dissection. And in the another part we do the another cut and we use the drainage inside the cuttings. A velar longitudinal incision can be used for superficial phalanx. The same precautions as stated above should be followed. It is not recommended to use the fish mouth incision, the hockey stick, or the transverse palmar incision, as these incisions have been associated with complications such as neurovascular damage and painful scarring. Packing should be removed in 24-48 hours and the finger should be re-examined by a physician. If there is an improvement and the wound appears to be healing, the piccan should be removed and the wound can be allowed to close by secondary intention. If there is no improvement within 12-24 hours, or if the felon is extensive or recurrent, a surgical consult may be needed. More often we don't do the secondary intention because it is not necessary. The cutting on the fingers is so small and never it lead to any problem for patients. What is important? The patients should receive a tetanus shot if not up to date. A first-generation cephalosporin or anti-staphylococcal penicillin to cover Staphylococcus aureus and streptococcal organism should be prescribed for 7-10 days. Doxycycline, trimethoprim, sulfamethoxazole, or clindamycin can be added if there is suspicion for MRCA. If the felon was a result of a bite wound, or if the patient is immunosuppressed, coverage for Escherichia coriodens may be indicated. Gram stain should be used to guide therapy when available. Often, when I have the patients with panorrhizum or felon, I don't use the antibiotic therapy because after your drainage, after your incision, the all problem go away and the all bacteria go away from the organism. But of course, we have any moments what I will discuss with you in the practice. Differential diagnostic: cellulitis, dermatomyositis, fingertip injuries, granuloma annulare, hematomas from pulse oximetry, herpetic Whitlow, pyogenic granuloma, paronychia, Reiter syndrome. About this we will talk in the next topic, paronychia. And the paronychia we discuss now too. How you understand the paronychia is the same like a felon, but the inflammation we have near the nail. Paronychia is an infection of the proximal and lateral fingernails and toenails folds, including the tissue that borders the root and sides of the nail. This condition can occur spontaneously or following trauma or manipulation. Paronychia is among the most common infections of the hand. Paronychia results from the disruption of the protective barrier between the nail and the nail fold, introducing bacteria and predisposing the area to infection. Acute paronychia is usually limited to one nail, however, if drug-induced, it can involve many nails. Etiology. We have classification to the clinical presentation, and there we talk about acute and chronic paronychia. Acute, lasting less than 6 weeks, painful and purulent condition, most frequently caused by bacterial infection, especially staphylococci. Chronic, usually caused by mechanical or chemical factors and sometimes infectious etiology like a fungal infection, especially Candida species. Risk factors include occupation, dishwasher, bartender, housekeeper, certain medication and immunosuppression, diabetes, HIV, malignancy. Classification can also be by etiology. Bacterial commonly staphylococci, viral commonly herpes simplex virus, fungal commonly Candida species. Non-infectious cause of paronychia can include contact irritants, excessive moisture, and medication reaction. Paronychia is more common in women than in men, with a female-to-male ratio of 3:1. Usually they affect manual labor workers or patients in occupations that require them to have their hands or feet submerged in water for prolonged periods. Middle-aged females are at the highest risk of infection. Pathophysiology. Paronychia results from the disruption of the protective barrier between the nail and the nail fold, which is the cuticle. Trauma, including manicures and pedicures, for example. Infections, including bacterial, viral, and fungal. Structural abnormalities and inflammatory diseases, for example psoriasis, are predisposing factors. Organism will enter the moist nail cervix, which leads to colonization of the area. The majority of acute paronychias are due to trauma, nail beating, aggressive manicuring, artificial nails, and may involve a retained foreign body. Infections are most commonly the result of Staphylococcus aureus, streptococci, and Pseudomonas are more common in chronic infections. Less common causative agents include gram-negative organism, dermatophytes, herpes simplex virus, and yeast. Children are prone to acute infection due to habitual nail biting and finger sucking, leading to direct inoculation of oral flora, which would include both aerobic bacteria and anaerobic bacteria. History and physical. Paronychia is most commonly an acute inflammatory process causing painful redness and swelling to the lateral nail fold and is primarily diagnosed based on clinical presentation. The patient will usually present within the first few days of infection due to the pain. History may include recent trauma, infection, structural abnormalities, or inflammatory diseases. Occupation and working environment are critical historical findings. Homemakers, bartenders, and dishwashers seem predisposed to developing chronic paronychia. Past medical history inquiries should include any debilitating illness, like diabetes and HIV. A list of medications the patient is currently taking may help determine the cause of chronic paronychia. Physical exam for acute paronychia will reveal an erythematous swollen and tender lateral nail fold. If an abscess is present, there may be an area of fluctuance. If there is an uncertainty of an abscess present, a digital pressure test may prove useful. The examiner can do this by applying pressure to the volar aspect of the involved digit. If an abscess is present, a large than expected area of blanching will be visible at the paronychia and drainage will be needed. In chronic paronychia, the nail fold may be red and swollen, but fluctuance is rare. The nail fold may appear boggy, and the nail plate can become thickened and discolored. Other common findings of chronic paronychia may be a retraction of the proximal nail fold, nail dystrophy, and loss of the cuticle. Evaluation. To diagnose a paronychia, you will need to obtain a good history and physical, revealing a swollen and tender nail fold, as there is no laboratory testing of imaging that will lead to the diagnosis. The infection is usually straightforward, however the presence of an abscess is not always evident, and the digital pressure test described above can be used to get you. Paronychias are usually easy treated, with incision and drainage or antibiotics. If there is inflammation with no defined abscess, treatment can include warm soaks with water or antiseptic solutions, chlorhexidine, povidone iode, and antibiotics. Warm soak should be for 10 to 15 minutes, multiple times a day. There is not strong evidence recommending topical versus oral antibiotics, and this may be physician-dependent based on experience. Antibiotic use should have Staphylococcus aureus coverage. Typical antibiotic use may be a triple antibiotic ointment, bacitracin, or mupirocin. In patients failing topical treatment or more severe cases, oral antibiotics are an option, dicloxacillin or cefalexin. Indication for antibiotics with anaerobic coverage include patients where there is a concern for oral inoculation. This would require the addition of clindamycin or amoxicillin clavulanate. If the patient has risk factors for MRCA, including but not limited to recent hospitalization, recent surgery, ESRD on hemodialysis, HIV, AIDS, IVDU, resident of long-term care facility, choose an antibiotic with the appropriate coverage. Options include trimethoprim, sulfamethoxazole, DS 1 to 2 tablets twice a day, clindamycin 300 to 450 milligrams 4 times a day, or doxycycline 100 milligrams twice a day. If an abscess is present, the infection will require drainage. Incision and drainage are usually with a 11 scalpel, and the blade is inserted under the aponychial fold, lateral nail fold, until pus begins to drain. Local or digital block anesthetic is generally helpful to allow comfort to ensure complete drainage. An abscess requires irrigation with normal saline, and if the abscess and incision site is large, the clinician can pack it with plain gauze for continued drainage. If the abscess extends to the nail bed or is associated with an ingrown nail, a partial nail plate removal may be needed. More often, I don't do the cutting in the skin, always I do the small onychal of this part. I will give the links to the video of my work in the comments. If an abscess is present and not drained, it can spread under the nail to the other side and result in an run-around abscess. This scenario may require complete removal of the nail to allow adequate drainage and treatment. Not do always the all nail removal. Do the part nail removal. It will be better for patient and for wound healing. Warm soak should be initiated after incision and drainage to encourage continued drainage by keeping the wound opened and prevent secondary infection. The patient should follow up with a provider in the next 24 to 48 hours to ensure drainage and to look for signs or worsening infection. Usually incision and drainage is the adequate treatment of acute paronychia. However, if there is a significant extension of cellulitis, oral antibiotics may be prescribed as above. In chronic paronychia, the patient should be instructed to avoid trauma as to the hands as much as possible. Wearing gloves is advised for manual workers. Treatment in chronic paronychia should point toward fungal etiology. Topical and systemic antifungal agents such as itraconazole and terbinafine are options since the etiological factors in chronic types is mostly Candida species. Other inflammatory diseases of the digital, like ingrown nails, psoriasis, should have treatment as well. In difficult to treat chronic paronychia, other causes such as malignancy merit exploration. Differential diagnosis there. And first of all, we talk about the cellulitis. It's a superficial infection and will present as erythema and swelling to the affected portion of the body with no area of fluctuance. Treatment is with oral antibiotics. Felon is a subcutaneous infection of the digital pulse space. The area becomes warm, red, tense, and very painful due to the confinement of the infection, creating pressure in the individual compartments created by the septa of the finger pad. This requires excision and drainage, usually with a longitudinal incision and blunt dissection to ensure adequate drainage. Herpetic Wieslow. There is a viral infection of the distal finger caused by HSV. Patients usually develop a burning, pruritic sensation before the infection erupts. A physical exam will show vesicles, vesicopustules, along with pain and erythema. It is important to not confuse this with a felon or a paronychia, as incision and drainage of herpetic Wieslow could result in a secondary bacterial infection and failure to heal. Onychomycosis is a fungal infection of the nails that causes whitish, yellowish discoloration, sometimes difficult to treat and requires oral antibiotics instead of topical. Nail psoriasis. Psoriasis can also affect the fingernails and toenails. It may cause thickening of the nails with areas of pitting, ridges, irregular contour, and even rising of the nail from the nail bed. Squamous cell carcinoma is mainly cancer of the skin but can also affect the nail bed. It is a rare malignant subungual tumor subject to misdiagnosis as chronic paronychia. Prognosis. Paronychia usually has a good prognosis. Acute paronychia usually resolves within a few days and will rarely recur in healthy individuals. Chronic paronychia may persist for several months or longer and may recur in predisposed patients. Acute paronychia can cause a severe infection of the hand and may spread to involve underlying tendons, which is why appropriate treatment on initial presentation is essential. The status may require evaluation and treatment by a hand surgeon, as it often involves debridement, washout, or amputation, based on the severity of the infection. The major complication of chronic paronychia is nail dystrophy, how you see in onychomycosis, for example. It is psoriasis. It is often associated with brittle, distorted nail plates. Nail discoloration is not an uncommon complication of chronic paronychia. Thank you very much, guys, for your attention, and have a nice day. Bye bye.